Thank you, Arti, for the kind introduction, and thank you for inviting me to be here. It's a pleasure. I'm going to be talking about sex, and specifically compared to the two elegant talks that you've heard, I don't have a very clear recommendations, but I do want to hope to convince you that sex matters in psoriatic arthritis, but it's also relevant to many of the other rheumatic conditions that we see as rheumatologists. These are my disclosures, and specifically, I do hope to convey the message that we should be thinking about moving from a gender-blinded to a gender-specific approach. We talk a lot about personalized medicine and finding biomarkers to help us manage patients better and select the right drug for the right patient, but we tend to ignore a very important biomarker, and that's the sex of the patient. We assume that what works for one sex automatically works for the other sex, and that assumption may not be correct. The issue nowadays in terms of trying to apply this approach in rheumatology is that there is still a significant gender data gap, and we need to be aware of this. But I do hope to show you what we do know and also highlight some of the gaps in care and how we can apply it in clinic. So there are a few examples where there are sex-specific recommendations. One is cardiology, where there are guidelines for primary prevention of cardiovascular diseases in women, specifically in women. Another obvious example is osteoporosis, of course, where there is differences in biology and differences in recommendations for men and women. But in rheumatology, we typically don't consider sex when we manage our patients, maybe apart from considerations regarding pregnancy. So when we talk about sex and gender, it's really important to understand the definitions of sex and gender, because they are often used interchangeably in the medical literature. When we talk about sex, we consider biological-based constructs that define differences between males and females. And when we consider psoriatic arthritis or rheumatic diseases, this could mean differences in genetic inheritance, in expression of genes, in pain mechanisms, in pharmacokinetics of drugs, and in differences in the immune system. Gender, on the other hand, is a complex construct. It relates to sociocultural aspects of being man or woman or another gender, and it really defines or influences the way people behave and the expectations that the society has for men and women. And you can imagine that it would change as we look at different societies. Being a woman nowadays in a Western society is very different than being a woman in more traditional society or 100 years ago in North America. So why is this important for us? It could influence the way our patients behave, how soon they seek help for their symptoms, their risk-taking behavior, whether they smoke, whether they use alcohol, what type of occupation they have, and it also would influence the interaction with their physician, their access to care. So when we think about rheumatic diseases, we know that there are clear differences in disease susceptibility between male and female patients, and generally speaking, autoimmune conditions like lupus and Sjogren and rheumatoid arthritis are more prevalent in female patients, and on the other hand, radiographic axial SpA and gout are more common in males. Psoriatic arthritis affects male and females equally, but there are a lot of differences in the way it presents clinically. And there's been quite a lot of studies that show consistently that female patients tend to have higher scores in pain-sensitive domains. So they have higher tender joint count, higher enthesitis count, higher pain scores, and they also experience more physical dysfunction and fatigue and lower quality of life. Male patients with psoriatic arthritis, on the other hand, tend to have higher levels of CRP. They tend to have more restriction in the spine mobility, and they also have more severe psoriasis. There seems to be an equal prevalence of extra-articular manifestations like IBD and uveitis, and similar swollen joint count between male and female patients. There are also differences in imaging findings, and this has been shown both in PsA as well as in AxSpA, where male patients tend to develop more radiographic damage, and this could be seen both in the peripheral joints as well as in the spine. Male patients would have more radiographic sacroiliitis and would more likely to develop erosions over time. Now, why is this important? Because if we rely only on X-rays when we consider a diagnosis of ankylosing spondylitis or axial SpA or PsA, we may miss more subtle disease that does not cause damage, maybe at earlier phases, and therefore considering using more sensitive modalities like MRI and ultrasound in female patients may be a way for us to avoid this potential bias. And I'll talk about delays in diagnosis, and this might be one of the reasons why female patients tend to have longer delays for the diagnosis. It's also, of course, important to know the mimickers of sacroiliitis that are more common in female patients, in this case, osteitis condensus iliae, the sclerosis that can be seen in the iliac side of the sacroiliac joint may be confused with sacroiliitis in female patients, and this may lead to misdiagnosis of patients as having axial SpA, while in fact this is not a real diagnosis of axial SpA. So important to be aware of these differences. So I've shown you that there are differences in the clinical presentation. So what is driving these differences? This still remains unknown, but there are some common themes that or some common knowledge that we could learn from other conditions. And pain is an important factor. I've shown you that women have higher scores of pain, they have more tender joint count, and generally speaking, it's been shown across different diseases that female patients tend to report higher scores in pain scores or pain levels across different types of rheumatic conditions. Also in experimental pain models, female patients would tend to show lower pain thresholds. So this is, for example, is assessed when asking patients to place their hand in ice cold water, and women will more likely to withdraw it sooner than male patients. It's also important to recognize that there are differences in the way men and women report pain. So female patients with established rheumatic diseases are more likely to report diffuse pain that we as rheumatologists may be considered to be atypical or related to fibromyalgia. So this could add to the confusion that we may have, but it's important to realize that the way men and women report pain and this atypical type of pain may be more common in women patients, even though they do have established inflammatory condition. And pain is, of course, a subjective factor, but it has a biology behind it, and with more recent data and research into differences, we start to understand that there are some qualitative differences in the way pain is transmitted from the periphery and processed in the central nervous system. So it's been shown, for example, that microglia cells are important in pain processing in male patients, while T cells are important in female patients, and that this is influenced by testosterone levels. So with lower testosterone levels, there is a shift toward this T cell predominant pain processing. And this is important because many of the basic science research is limited to male animal models, and if medications are targeting specific cells or processes that are more predominant in male patients, this may miss important targets that are important in female patients, and medications that were designed may not work as well in female patients. So this is really just evolving, but there are some important differences in the biology here. But there are also some other gender-related factors, and this has to do with gender roles. And typically in many societies, there are differences in the way boys and girls are brought up, with boys. There is a sort of an expectations in many societies that boys will endure pain, and showing pain might be considered as a weakness. And for girls, it's okay to say that they have pain or report pain or verbalize it. And this may lead to differences in the way men and women report pain when they are grown up, where men may be more inclined to report lower levels of pain or to ignore pain and endure it because it would be a sign of weakness. So it's important to know these differences and to realize that it's not just biology, it's a complex mechanism. I mentioned some differences in immune system. We have very little data. Most biomarker studies in psoriatic arthritis and axial SpA do not report the results by sex, and there is typically sort of looking at everyone together and assuming that the biology is similar. But this is a very interesting study that was done in axial SpA, showing that in fact there are some important differences in gene expression between male patients and female patients, showing that the Th17 pathway is more active in male patients with AS, while the Th1 pathway is similarly active in male and female patients. So while we have very little data at this point, there are some important clues that there are differences also in the biology, and this potentially might inform us in terms of development of biomarkers and maybe even selection of drugs. So how else these differences could influence our practice? This is one way. So what tools we use to measure disease activity? This is an example that has been studied a lot using BASDAI or ASDAS. BASDAI, as you know, both of them are tools that are used to assess disease activity in axial SpA to treat to target. BASDAI is based on these 5 questions, and on the other hand, ASDAS is a combination of patient-reported outcomes and CRP levels. It's been shown in multiple studies and in meta-analysis that BASDAI tend to be higher in female patients compared to male patients, while ASDAS tend to be equal, probably because of applying more weight to the back pain component, as well as including the CRP component here, which tends to be higher in male patients. So knowing which tool to use and the differences that can be found when we use these tools between males and females. Another example, this is a study that was just published on PsA, and looking at 2 treatment targets, so minimal disease activity, MDA, and DAPSA remission. And they compared the discrepancy between what the physician and the patient thought is remission compared to these cutoffs for these different tools. They showed first that when looking at the physician as the gold standard for remission, both tools function about similarly, maybe a little bit more discrepancy for the female patients with the MDA, but certainly the MDA seemed to be performing better than the DAPSA, showing less discrepancy between the cutoff and what the physician thought. But when looking at what the patient thought is remission, you can see here that while for the DAPSA, both of these tools, the DAPSA and the MDA, both of them seem to be reasonable in terms of achieving these sensitivity and specificity targets for male patients. For female patients, there was a more discrepancy with the DAPSA score. So the bottom line is that we're just starting to look at these differences and what cutoff, and should we be using different cutoff for males and females? Should we think about different targets, different tools? This has been sort of ignored so far, but there are some clear differences that we may need to think about in the future. Another area that there has been studied for differences in sex differences in rheumatology is the diagnostic delays. And we know that this is a big issue and big problem in axial SpA. And it's been shown consistently that female patients tend to have a longer time to diagnosis compared to male patients with over 2 years difference. We've looked at it in the Ontario data looking at RA, PsA, and axSpA, and the time to the diagnosis, especially the journey that the patient goes through until they actually receive a diagnosis of these conditions. And we looked at the 3 years prior to the time they receive a diagnosis and looking at visits to family physicians for non-specific musculoskeletal symptoms. So many of the patients are seeing their family physicians and are being referred to physio or to other physicians or to rheumatology. And we were interested to see whether there are differences in males and females. As you can see here, we did find that there was a slight difference across these different diseases with about 10 to 15% higher visits or more visits to family physicians up to 3 years prior to the diagnosis, but this was a relatively small difference. The bigger difference here was actually visits to rheumatologists. We found that between 50% to twofold higher chances females were more likely to visit the rheumatologist, but did not receive a concrete diagnosis of inflammatory arthritis, which means that probably women require more visits to rheumatologists until the rheumatologist is confident enough to make a diagnosis of these conditions. And you can see that the differences were particularly higher for axSpA and for PsA. So why is that? There are several potential reasons. I mentioned the use of imaging. It's possible that female patients are seeing rheumatologists sooner, maybe at an earlier stage of the disease before there are very clear signs of inflammation, maybe the way they report pain, maybe some comorbidities, and maybe the way rheumatologists interpret the symptoms might be different in males and females. But I want to also mention biases because I think this is important for us to be aware of our own biases as human beings. We all have biases. And this is the slide that I showed you before. If we assume that men are strong and brave, that maybe if they see us, then it must be real. And if women, it must be their anxiety that is acting up. So, I mean, it's important to be aware of this. And there is data to support that the fact that there are differences in the way clinicians are in managing men and women, with more women receiving psychosomatic diagnosis for musculoskeletal pain. Women are less likely to receive effective pain relief medications, and more women with chronic pain feel more mistrusted by their physicians. So, I mean, as clinicians, we need to be aware of our own biases, and that's a first step to try and mitigate these biases. Finally, I wanted to discuss this really exciting topic of sex-related differences in treatment response, because I think this is where, in the future, we might consider also using sex as a way to inform selection of treatment. So, there is very little consideration of sex in the development of pharmaceutical or drugs, starting from basic science to phase 1 and phase 2 trials, and that may lead to the fact that most of the prescription drugs that are withdrawn from the market, it's because of safety issues that is greater in female patients. And we typically don't consider sex when we prescribe medication, but this is one unusual case where the FDA approved different doses for Zopiclone, which is a sleeping pill, recommending starting at a lower dose for female patients because of safety issues. So this is an unusual example, but there is a gap of data that we just don't know whether to consider sex when we prescribe the drugs. So what do we know about medications and a response to treatment in PsA? Most of the data is coming from observational studies, and most of the studies were done on TNF inhibitors. This is one example, but most of the studies were pretty consistent in the results showing lower effectiveness in female patients, with female patients less likely to achieve efficacy endpoints in the short term, but also lower persistence of TNF inhibitors in female patients. And females are more likely to stop these medications because of both inefficacy as well as adverse effects. So this has been shown in multiple studies in PsA. Fewer studies on other modes of action. This is an example from a ixekizumab trial showing that female patients are less likely to achieve ACR response and a minimal disease activity state. And some data on JAK inhibitors, in this case, upadacitinib. And the interesting finding here is that when you look at the response, ACR response for upadacitinib in males and females, you can see that they actually overlap, while the adalimumab, that was the active control arm, was showing what we expect, a better response in male patients. So this triggered us to perform this meta-analysis where we're asking ourselves, okay, we want to look at different classes of medications and whether there is any actual differences across classes by sex. So this was published just last month in Lancet Rheumatology, and we reviewed a total of 54 trials in psoriatic arthritis. As expected, 50% of the participants were males and 50% females, as in the general population. One key finding here is that there is limited reporting of sex disaggregated data, so most trials do not report it, or it's very hard to find it in the supplement, even though it is required as part of the approval process for the FDA to assess response by sex. And you can see only about a third of the trials reported some efficacy endpoint by sex, and only 4% reported safety data by sex. As expected, we've found that female patients had higher burden of musculoskeletal symptoms at the time of enrollment, higher tender joint count, higher pain score, more physical dysfunction. Male patients had higher CRP levels, higher PASI scores, and were more likely to have dactylitis. This was really interesting for us, and this is the summary of the meta-analysis of responding to these different classes of medications by sex. And I'll draw your attention first to the bottom part, which is the total effect, regardless of the drug class. And you can see about 50% higher chances of achieving ACR20 response in male patients. But really the interesting finding here is that you can see that across the three monoclonal antibodies, TNF inhibitors, IL-17, IL-23 inhibitors, there was a preferential response of male patients compared to female patients, while for the JAK and TYK2 inhibitors, there was absolutely no difference. This includes 3 types of JAK and TYK2. We also looked at ACR50 that showed similar results. And the other important finding here is that looking at the placebo response by sex, there is absolutely no difference. So this is not just a subjective thing. There seems to be maybe a biologic mechanism behind these differential response by sex and by class of medication. Because of the nature of the data, it was impossible for us to look at potential mechanisms, but there are some potential thinking about whether this is differences in pharmacokinetics of drugs or pain control abilities of the different mode of actions or other factors that we hope to explore. And just drawing your attention to this ongoing study that is called SAGE PsA. It's a big study that we run in GRAPPA that aims to try and understand the mechanisms and maybe separate the biology from the sociocultural aspect and specifically collect data that is not typically collected in clinical trials and try to understand what are the underlying mechanisms behind these differential responses. So take-home messages. I hope I convinced you that there are differences in the clinical presentation, the course and response to treatment between male and females with psoriatic arthritis. some of these differences can also be applied to other rheumatic diseases. It's important to consider these sex differences when we evaluate the patient in the clinic, when we consider the diagnosis, when we consider what imaging to order, and when we monitor disease activity, it will influence what tool we want to use. I also wanted to mention the bias. Be aware of your own bias when you evaluate patients. And recognition of the gaps, trial designs, and reporting of data needs to be improved, so it will help us better understand these differences, identify them, and maybe inform prescription of medications in the future. So this is my team in Toronto and our funders, and I would like to thank you for your attention.